Well, good evening, everyone. Welcome to our webinar tonight. Thank you for joining. My name is Scott Allen. I am the CEO of the Family Medicine Education Consortium, and I'm excited that we're going to be sharing this content with you tonight. We have been working with about 10 family medicine residency training programs on a learning collaborative around hereditary breast cancer. And we have some great information from that collaborative, as well as a wonderful guest speaker tonight to talk more about hereditary cancers and what you all as family physicians and other healthcare providers can do. So with that, I'm just going to quickly do some opening remarks. We're going to talk about a little bit about our collaborative. We're going to have a guest presentation from Dr. Puri Welsh from FORCE, and I'll introduce her in just a moment. We're going to talk a little bit about the Bring Your Brave campaign and the resources that we hope you will all go find after the webinar and really dig into, because they're wonderful tools for you to use in your practice and in your training. And we're going to talk about narrative medicine because that's the foundation of those tools. Give a little bit of an update on what we've learned from our collaborative so far, and then if we have time, we'll do some Q&A. But if you have questions now, feel free to use the chat, put them in the chat, and we will try to get to them as we're able. So just quickly, our learning collaborative through the Family Medicine Education Consortium was funded by the CDC through the National Association of Chronic Disease Directors. So we are really thankful to them for the support and the guidance and for creating the Bring Your Brave campaign to begin with. Our goal was to introduce a set of residency training programs to the campaign materials and talk to them about how they might use those tools in practice, but also in training, so that they become something that family medicine, family physicians, family medicine practitioners come out of training knowing how to use. Our collaborative partners were the 10 residency programs throughout the Northeast US, with about 33 individual members, 12 faculty and 21 residents who worked with us through a series of learning sessions to explore the materials and provide their feedback. So tonight we have our advisory committee members who are on the screen, and I will let them introduce themselves as they speak. But our first speaker tonight is going to be Dr. Puri Welsh. Dr. Welsh has been a researcher focused on the identification of inherited cancer susceptibility genes for over 25 years. She was finishing her PhD in molecular genetics at The Ohio State University when she read the groundbreaking research paper by Dr. Mary Claire King describing the location of BRCA1. Guided by this pioneering research, she committed herself to the study of inherited cancer, and her postdoctoral project at the University of Texas Southwestern Medical Center was in collaboration with Mary Claire's groups and others to clone BRCA1. She currently serves as Vice President of Education for FORCE, which is Facing Our Risk of Cancer Empowered, which is the leading national advocacy organization for hereditary breast and ovarian cancer. So with that, I'm going to stop sharing my slides and ask Dr. Welsh to join us and talk, give her talk.
So thanks to everyone for joining tonight. I'm going to go a little bit off script because what I've learned over the years is, well, hereditary breast cancer is a large component of hereditary cancers. We've learned a lot over the years, and it's not just hereditary breast cancer. So cancer can be hereditary, which means it runs in families. There can be families with a lot of breast, ovarian, prostate, colorectal cancers. And I think family medicine residents and docs are kind of on the front lines. I think you heard a presentation a little while ago about how important it is to incorporate into your practices, really understanding what your patients' hereditary cancer predisposition may be, understanding the patterns of hereditary cancer in a given family, and how knowing this information can help not only, a patient that you're helping, but subsequent generations, which is what family medicine is all about. So this is a picture of the first family that Mary Claire King collected, and what you can see in this family is that it taught us a lot early on, and it continues to teach us. So this family was ascertained on the fact that there was a lot of breast cancer, and a lot of breast cancer that occurred early. So, oops. So if you look at the age of diagnosis in some of these patients with breast cancer, 29, 28, 25, 27. So this family pedigree was expanded, and over the years, it has taught us and continues to teach us a lot. So this family has a BRCA1 mutation, and that's designated by a V under the pedigree symbol. So you can see that a lot of these early onset breast cancer patients had inherited the mutation that runs in this family. However, there are also early breast cancer patients in this family that do not have the familial mutation. So there can be cases of breast cancer in a family that look hereditary, but there actually aren't. And when you go back through this family and start looking at the other cancers, and this is one of the things I mean by how this family has continued to inform us, you can see that there's a male here, 91, who inherited the familial mutation that never was diagnosed with cancer. Similarly, another male here who inherited the variant, again at 94, was never diagnosed with cancer. But what you can also see when you go back a couple generations are cases like this woman who was diagnosed with breast at an early age, 45, also diagnosed with ovarian cancer, a mutation carrier here that was diagnosed with prostate cancer, another mutation carrier here with prostate cancer, another mutation here, carrier here with prostate cancer, and also pancreatic cancer. So what we now know, is that people with an inherited BRCA1 mutation are not only at higher risk for breast cancer, they're at higher risk for ovarian cancer, secondary cancers, and men are at higher risk for prostate cancer, and everyone in the family with a mutation is at higher risk for pancreatic cancer. So even though this was one of the first families that Mary Claire collected, it still, over the years, has taught us a lot. And I just show this slide here to emphasize that, you know, some of the cancers that we look at, like breast cancer or prostate cancer, are very common. But there's a percentage of people that are diagnosed with these cancers that have an inherited mutation. So generally what people, experts in the field, quote now is about 10% of all cancer has a hereditary component. And why is this important? So this is from a study that looked at incidence of breast, ovarian, uterine, and colorectal cancers. And the annual incidence when the study was done is shown here. But we now know that the percentage of all of these cases in this given year, 12 to 14% were hereditary. And look at ovarian. Up to 25% of all ovarian cancer cases are hereditary. And, you know, uterine and colorectal, this is kind of the Lynch syndrome cases I'll talk about in a minute. And, you know, could these cancers, you know, what percentage of cancers could have been prevented had people known that they had an inherited mutation? So some mutations are very common in certain populations. So it's estimated that about 1 in 400 Americans carry a mutation, either BRCA1 or 2, but you may be familiar with the fact that about 1 in 40 people of Ashkenazi Jewish descent carry a mutation in either BRCA1 or 2. And as I emphasized using family 1 as an example, we now know that mutations in these genes and other genes, ATM, CHEK2, P10, TP53, there are a lot of other inherited mutations in other genes that we have identified since the cloning of BRCA1 and 2 that similarly increase the risk of breast, ovarian, prostate, and pancreatic cancers. And you may be familiar with Lynch syndrome. About 1 in 300 Americans, so more than BRCA1 or 2 mutation carriers, have an inherited mutation in one of the Lynch syndrome genes. And people who have these mutations are at increased risk of, colorectal, ovarian, endometrial, and other cancers. I think currently there's about 12 different cancers that a person with an inherited Lynch syndrome mutation will have an increased risk for. So there are 5 genes in Lynch syndrome, 1 gene. These are the genes. And again, like we found with breast cancer, there are other genes that increase someone's risk for colorectal. They're listed here: CHEK2, B10, STK11. So really what we're learning is that there are a lot of inherited mutations in a wide variety of genes that increase risk of cancer, not just breast cancer, but ovarian, prostate, colorectal, and other cancers. I show this slide a lot. So just looking kind of back to our focus on breast cancer and women with inherited mutations, the average risk of a person with no mutation in any of the known breast cancer predisposition genes is about 12 to 13% currently. But lifetime risk, look at how much it goes up for BRCA1, 65%. Again, P10, Cowden syndrome is a little more rare, but the lifetime risk of breast cancer is even higher in P10 mutation carriers. And there are these other genes, which sometimes we refer to as moderate penetrance genes like CHEK2, but still, when you look at someone without an inherited mutation and someone with a CHEK2 mutation who has a lifetime risk of about 35%, that's a dramatic difference. And one of my, it's not really a pet peeve, but one of the things we really tried to emphasize at Force is these mutations are inherited in men just as readily as they are inherited in women. So men, it's breast cancer is exceedingly rare in men without a mutation. But look how much the breast cancer risk in men goes up with a BRCA2 mutation. This is, not even 1%, it goes up to about a 7% lifetime risk in men with a BRCA2 mutation or in men with a BRCA1 mutation. So, when you're thinking about breast cancer and hereditary cancer risk, it's not just the women that we have to be conscious of, it's also the men. And I think this is best exemplified by Beyonce's father, who developed breast cancer, and he indeed is a BRCA2 mutation carrier. So some of the characteristics of hereditary cancers that you probably should be aware of, these cancers that I showed in the family 1, these hereditary cancers often develop at a younger age compared to the general population. So, breast cancer in a family in women who are in their 30s versus, breast cancer in the general population, maybe developing, 60s and 70s. Another point that was that I tried to highlight in that family 1 was that there's a higher risk in mutation carriers for a second or third cancer diagnosis, be that, a woman's diagnosed with breast cancer and then, is diagnosed with subsequently with ovarian cancer, or diagnosed with breast cancer, then diagnosed years later with another primary breast cancer in the contralateral breast. So that's another kind of key to whether or not the cancer in the family is hereditary. There are more people in the family that will develop a second or third cancer diagnosis. And since the cloning of BRCA1 and 2, there's been a lot of emphasis on developing treatment options for people with certain inherited mutations. So you may have heard about PARP inhibitors that specifically target a protein that's involved in the DNA repair pathway that BRCA1 and 2 are involved in. So those treatment options are targeted therapies for people with inherited or more broadly now, whose tumors, they may not have an inherited mutation, but whose tumors may have a mutation in BRCA2. As a matter of fact, one of the PARP inhibitors was recently approved by the FDA a week or two ago for treatment of men with metastatic castration-resistant prostate cancer whose tumors show a mutation or who have an inherited mutation in genes involved in the homologous recombination repair pathway. And again, since more and more people are being tested, I think it's important for families with these mutations to understand that these mutations can be passed on to their children. So it's kind of teaching your patients genetics 101, regardless of whether the mutation is in the mother or the father. There is a 50% chance of passing that mutation on to your biological children. And importantly, Force coined the term previvor years ago to define patients who have a known inherited mutation but have not yet developed cancer. So previvors have a known inherited mutation and have not yet developed cancer. And often, so a previvor with a BRCA1 or 2 mutation or a Lynch syndrome mutation are going to have very different guideline recommended screening and risk management options available to them. So be it, MRIs and mammography, beginning at, 25, 30, or, similarly for Lynch, colorectal cancer screening beginning before recommended general guideline screening starting. Again, previvors, people who have not yet developed cancer, have very different screening and risk management options to consider. And this is always a slide that kind of makes me step back a bit. So of all the people who have a predicted inherited mutation that increases their risk for hereditary cancer, 90% of these people have no idea that they have an inherited mutation in one of these genes that could increase their cancer risk. And we've done a lot of work, researchers have done a lot of work, and it's still difficult to identify people who should be have genetic testing. And even once a member of a family knows that they have an inherited mutation, it's often difficult to get the rest of the family involved in what we call cascade testing, so testing other family members who are at risk. And there are a multitude of causes for this, but we are missing the vast majority of people who have an inherited mutation that will significantly increase their cancer risk. So what can you do to help? You can identify those patients who need genetic counseling based on genetic counseling testing based on some of the factors that I outlined earlier. So early onset cancer, cancer running in the family, multiple cancers, and now NCCN guidelines recommend that anyone diagnosed with ovarian cancer, metastatic prostate cancer, be recommended to have genetic counseling testing. And it's hard to explain to patients why they might need genetic counseling and testing. And I'll talk a little bit about that, the benefits, the pros, and the cons. And also, I'm going to present some of the resources that FORCE has so you can help your patients connect with some of our resources. So just to reiterate, who should consider genetic testing? If there's a known mutation in the family, of course. If a blood relative has tested positive for an inherited mutation in BRCA1, that family member should consider genetic counseling testing. Also now, because a lot more tumors are being screened for mutations associated with hereditary cancer. If a family member, is diagnosed with pancreatic cancer and that cancer is tested and it turns out the tumor has a mutation in BRCA1, it's possible, and the testing is robust enough now that we can determine, was that a tumor only mutation or was that an inherited mutation? So people who have family members who have tumors that have had a positive test for a mutation associated with the respective cancer should also consider genetic counseling testing. And kind of the red flags, again, I've been stating this kind of throughout, early onset cancer. So cancer that occurs earlier than would be expected in the given population. Multiple primary cancers in one person, so a breast and ovarian cancer diagnosis, a bilateral breast cancer diagnosis, and certain pathologies also are more associated with hereditary cancer. So a triple negative breast cancer diagnosis or a colon cancer that tests positive for a tumor feature called microsatellite instability. And also rare cancers. I pointed out how rare male breast cancer is, but a male patient with breast cancer should consider testing for a hereditary cancer mutation. And again, ovarian cancer, pancreatic cancer, metastatic prostate cancer, the list continues to grow and evolve. And again, a strong family history of cancer going back to family line. More cancers that in the family would be expected by chance, 2 or more generations. For family 1 went back 4 generations, and a pattern associated with a known cancer syndrome. So hereditary breast and ovarian cancer syndrome may have people with both breast and ovarian, or maybe more ovarian, some pancreatic cancer thrown in there. So what we're beginning to understand about what the cancer spectrum looks like for people with these mutations is constantly evolving. So reviewing cancer risk assessment, I always think it's important to, at an annual exam, ask a patient, do you have any new family cancer diagnoses or personal cancer diagnoses? I come from a family that has a lot of breast cancer, no known mutation in gene, but I went in for my high-risk MRI and I had to let my doctor know that there was a new, indeed, breast cancer diagnosis in my family. The age of diagnosis, again, these cancers tend to occur earlier than expected in the general population. the types of cancer. So, if you see a family that looks like this, it's got ovarian and breast, that's kind of a red flag. The number of cancers. So if there's, in my mother's generation, there are 3 women and there have been 5 breast cancer diagnoses. And remember, it can also be on the paternal side. So, while this mutation, in this family is coming from the grandmother here, and she passed it to 2 of her daughters and a granddaughter, it's just as likely that a mutation could have come from, the grandfather on the side, and could have passed it to his son, who could have passed it, to his daughter. So really looking at both sides of the family. And if at all possible, and I know this is difficult in some cultures because cancer isn't really readily talked about, but if you can include 3 generations and 3rd-degree relatives, that's helpful information. So what are the benefits of genetic testing? If the results are positive, you can, of course, have the patient share them with other family members who may also be at risk. There could be, like I talked about, PARP inhibitors, therapies that can be useful for those cancers. If the results are negative, often there's sometimes a sense of relief, or sometimes survivor's guilt can be something that a patient might be dealing with. And there can be, less focus on really rigorous. But informed decisions, really, again, back to family medicine, inform about the future, and this can include, reproductive options. And the drawbacks are, as you would predict, lots of emotion. People are concerned about loss of privacy, cost, unexpected or uncertain information. So if someone has genetic counseling and testing, has a variant of uncertain significance, which means it's a mutation, but we don't know if it's associated with cancer, that can be uncertain. And again, a lot of emotional possibilities. I'm going to skip through, since I think I'm running out of time, what genetic counselors do, and kind of wrap up here with the fact that you as providers are not alone. Of course, as a national, highly regarded organization, has a lot of information and support for patients and families who are facing hereditary cancer. So we have support groups. Sometimes these are local. We have an excellent peer navigation program where we match people. They want to be matched with someone who has their same mutation, or they want to be matched with someone who lives near them. We have an extensive evidence-based collection of information on our website, which we keep up to date, and very active advocacy and public policy branch, and a research tool that I'll describe to you. One of the programs, this is our CDC-funded program, is examining the relevance of articles for you, or our X-ray program. We were mandated by the CDC to write X-ray reviews for breast and now metastatic breast cancer, but this program has been so popular that we've included other hereditary cancers, so prostate, colorectal, endometrial. And these are articles that often summarize current research at a very lay, patient-friendly level, so that patients can read these reviews and really figure out what does this new study mean for me? What does this new FDA approval mean for me? And also, we do topical articles. We're working on a piece on coping with sexual intimacy issues after following the breast cancer diagnosis. So these are all our portals, and I'll point out to you, we recently added a hereditary cancer risk portal. So articles in there may include, talking to your family members about, hereditary cancer, articles for pre-vivors. Of course, we created this because even as a scientist, sometimes it's hard to read scientific journals. And then when the media picks up a lot of these studies, often, the results are sensationalized and unreliable. Here's one example. We did a piece on this study in Nature, asparagine governs metastasis in a model of breast cancer. It wasn't even people, but, outlet picked it up. This grain causes cancer to spread. Asparagus linked to breast cancer spread, but that's not at all what the article or the science supported. We rate the relevance, the strength of science, and whether or not, this study is still being done in animal models or if it's post-approval. We also include guidelines and a piece that I think a lot of our users find really helpful. Questions to ask your doctor. And this was from an extra review on palliative care. And we also link to relevant clinical trials and other related resources, be it our force resources or our partners, for example, Love and Beyond Breast Cancer. We also have a search and enroll tool that we've developed so patients can search for clinical trials that may be particularly relevant for them. So, have you been diagnosed with pancreatic cancer, or do you want to be involved in a study that looks at, quality of life? So you can search current enrolling research studies, and unlike clinicaltrials.gov, our blurbs on given research studies are written with a very patient focused, very lay language. This is what this study is about. And these are just some of the studies that we have featured, and I'll just point out this SOROC study, which is a study looking at BRCA1 mutations and removal of the fallopian tubes with delayed removal of the ovaries to circumvent surgical induced menopause and really improve quality of life for these patients. We also have a program that sorry, I'm going a little over here, that we developed. It's very general. We call it Spot the Boast, and it's a little Quizlet that you can share with your patients, which will help them spot or learn how to identify information that they're finding, in their Google searches to see whether or not it's trustworthy. So that's been a well-received program that people enjoy, and I think it really helps people identify what they should look for in articles that they're finding online about, really scientists are going to cure cancer. Well, where does the study come from? Is there published research, peer-reviewed journal, things like that. That kind of simplifies that process for people. And people are going to do it. They're going to look for health information. So this helps them kind of understand what information they should be looking for in a given article, and helps them determine whether or not it's trustworthy. So with that, I'll close. I'm always happy to answer any questions. Here's our website, and there's my email. And yeah, thanks for your attention.
Great. Well, thank you so much, Dr. Welch, and thank you for sharing some of those tools that both patients and providers, I think, will benefit from, and Along those lines, I want to turn it over now to one of our advisory committee members, Dr. Susanna Evans, who is going to talk more specifically about tools that we learned about in the collaborative meeting, the Bring Your Brave campaign. So Dr. Evans.
Thanks. So like some of the resources that Dr. Welsh shared, Bring Your Brave is a great tool for addressing genetic risk for breast cancer. We've been experimenting with the Bring Your Brave tool through this collaborative. And so really, what is Bring Your Brave? It is a CDC campaign that provides information about breast cancer in women younger than age 45 by sharing real stories about young women whose lives have been affected by breast cancer. The campaign objectives are to encourage young women to learn their family history of breast cancer and ovarian cancer, to educate young women on the risk factors for breast cancer before the age of 45, to inspire young women to talk to their healthcare provider if they think they may be at high risk for breast cancer, to encourage young women to live a healthy lifestyle and be aware of their own breast cancer health, and to educate providers on the risk factors for breast cancer before the age of 45. It addresses some of the challenges, the barriers to having family conversations about their family cancer history, including family reluctance to discuss cancer or personal health, fear of bad news, lack of understanding of genetic conditions, guilt over passing on genetic risk, cultural norms that discourage talking about bad outcomes, and the desire to delay tough conversations. It outlines the motivators and the barriers to talking to providers and pursuing genetic testing. Some of the motivators: knowledge of family history, knowledge of the right questions to ask, supportive family members, comfort with the topic, and healthcare provider prompts. Some of the barriers are the perceived cost of genetic testing, the lack of health insurance, lack of access to health care, fear, lack of information, lack of trust, and provider attitudes. So these are some of the tools that are part of the exploring, part of the Bring Your Brave resources. Bring Your Brave itself is a website for talking about family history of cancer. It contains over 20 patient videos, each one addressing some of those barriers that we outlined earlier, and some provider resources that I'll talk to you about on a later slide. Story Center, this is a space with patient and healthcare provider videos. There is a workbook with an instructional guide for healthcare providers, which offers discussion questions and additional resources for educating patients about genetic testing. So really these are the videos and the workbook are really great places for us as providers to get started and to learn more. And then Cognito, the Let's Talk site, is actually a simulator. It's an interactive system that helps prepare patients for conversations with their loved ones about breast cancer and their genetic risk. So here's an example from the Bring Your Brave. Like I said, there's over 20 videos. These are two. I know we're really tight on time, but I'd like to try to show you the first video. It's only a little over 2 minutes.
I was 18 years old when my mother lost her life to breast cancer. At that time, I was in college and I was scared. Breast cancer has aggressively attacked 3 generations of women in my family, and I really felt like cancer was coming for me. It was only a matter of time. I had genetic testing, and that's when I found out that I was the carrier of the BRCA2 gene mutation. I knew that I had an increased risk of breast cancer. But I walked into my high-risk oncologist and I was just like, you know what? This is not for me. They've got the wrong person. And I immediately walked out. But eventually, an inner voice in me said, no, you need to go back. I realized I had not accepted my BRCA mutation. I was still grieving from losing my mother, and that I still had to continue to press forward. And so the second time I went in, I actually did see my doctor. She shared with me my different preventative options, and she was very aggressive. And I remember telling her, I really feel like you're treating me like I have cancer. I don't have cancer. And then she said something to me that really changed and shifted my perspective. She said, Ashley, I have to be aggressive. She said, because you have options. She said, your mother, she didn't have options. And so it was almost like a surrender. I just kind of threw my hands up and I just said, you know what? You're right. Let's explore those options. Eventually, I did have a preventative double mastectomy to reduce my risk of breast cancer. And, you know, I look at it like this. Breast cancer aggressively attacked 3 generations of women in my family. And through genetic testing, we can aggressively attack breast cancer.
So that's just one of the examples of, like I said, more than 20 really powerful videos on the Bring Your Brave site. Another tool is the Story Center. And in the Story Center, there's more patient stories. There's also healthcare provider stories. Again, really powerful for helping you feel motivated to have some of these difficult conversations with patients. And then this is the Cognito site that I talked about earlier, which is a simulator to help patients prepare for conversations with their loved ones about family cancer risk. And these are healthcare provider resources that are available on the Bring Your Brave page. It opens with a really powerful video from a provider who herself is a survivor of early onset breast cancer. It provides tools for assessing risk in young patients, strategies for managing risks, and then there's an early onset breast cancer provider risk assessment tool where you can plug in information and assess the risk. And then there's also 2 continuing education courses, one on the risk factors and 2 on engaging with patients around their risk. So Bring Your Brave makes really strong use of narrative medicine. And one of the things that we noted was that this was a new concept for many of the collaborative participants. So that became one of our focuses. I'd like to turn the discussion over to Dr. Philip Day to talk about more about narrative medicine.
All right, thank you, Dr. Evans. I'm just going to speak really briefly about narrative medicine. So narrative-based medicine, as you can see here, is an application, as we just saw in that video, of narrative ideas in the practice of medicine. And it sort of relies on the analogy that patients' stories of their illness is similar to other stories in literature, or just, you know, the way that we construct and communicate our experiences usually in a narrative form. And so it's a diagnostic and comprehensive approach that can be useful for acquiring, comprehending, and integrating different viewpoints, points of view, of all the participants in the illness experience. Next slide, please. And so there's a seminal paper in 2001 published by Dr. Rita Sharon, who really popularized the term, published the book, and then edited a volume. So it's been around for 20 years, but you know, really has been maybe not niche, but not as prevalent in medical education and in practice, but it's becoming more widespread. Next slide, please. Oh yeah, and there's the paper in JAMA. And so with narrative medicine, Dr. Sharon introduced this idea of the central competence or skill of narrative competence, which is the ability to acknowledge, absorb, interpret, and act on the stories and plights of others. Next slide, please. And so as you see here, what's highlighted in this quote that I pulled from that paper is that it really, this narrative competence, which takes practice and education and training and your own sort of writing and reflecting, but allows physicians to reach and join their patients in illness, recognize their own personal journeys through medicine, build kinship with and duties towards other healthcare professionals, and really brings us more into the discourse with the public about healthcare and healthcare needs. Next slide, please. And so, as you saw in Bring Your Brave, we really rely on what these resources is about utilizing patient stories and narratives to learn more about them, how they feel about their relationship to their own mortality, the context of the illness in their life and in their family life, what they know or what they think about what causes disease, and then dealing with some of these more complex emotions that, of course, arise in these conversations. And so, again, using this strategy or this approach, again, both diagnostically and clinically in a comprehensive way, it really helps patients, sort of contextualize, the meaning and experience that they have with their family history, with their own experiences with illness and disease and in healthcare, and really can sort of help motivate for screening or intervention or therapy by honoring and acknowledging the role of emotion in motivating folks to make healthy decisions. And I think that's my last slide. I wanted to. Oh no, excuse me. We had until we told our members to see what they knew about narrative medicine. I happen to be the co-chair of the Ethics and Humanities Collaborative for Society of Teachers of Family Medicine, and so we get a little bit of narrative medicine that way. But in polling our participants, almost 3/4 had no formal narrative medicine training, and that's not too surprising. It's not that much in undergraduate or in graduate medical education, but almost all of them said that they had little knowledge but wanted more. And so we've been able to offer a little bit of education in that way for them as well. Next slide, please. Okay, yeah, but before we get there, my colleague, Dr. Adam Perrin, wanted to say something about narrative medicine. I know that he's had some training in that. So Adam, over to you.
Great, thank you, Phil. Hi, everybody. I just wanted to qualify what Dr. Day had said about narrative medicine. That's something that I am taking the deep dive into now and getting some formal training through Columbia and Dr. Sharon. I just first wanted to just give one little statement in terms of its definition, and that is this. Beyond attempts to reach accurate diagnoses, narrative medicine, it aims to address the relational and psychological dimensions that occur in tandem with physical illness. Narrative medicine aims not only to validate the experience of the patient, it also encourages self-reflection in the physician. And that, of course, helps us grow, helps us gain empathy, and brings us more sense of purpose in what we do. And lastly, just a few sentences from, this is Dr. Sharon's first publication, Narrative Medicine, Honoring the Stories of Illness. And as an example of its application to a breast cancer patient, I give you this, and I think it's really quite powerful. So as there is this African-American poet who writes the following: each woman responds to the crisis that breast cancer brings to her life out of a whole pattern, which is the design of who she is and how her life has been lived. Although an illness might trigger dissociation from life, it can also distill the life, concentrate all its deepest meanings, heighten its organizing principles, expose its underlying unity. This is not to say that illness is a gift, even though several authors of illness narratives indeed describe gifts, such as the heightened sense of hearing for the blind person, or the realization of the worth of the mind for the paralyzed person, but rather that as it takes away, illness also gives searing clarity about the life being lived around it. So there you go. There's a sense of narrative medicine principles, its application, and how it can expand upon what someone, in this case, a woman suffering from breast cancer, is thinking about experiencing and is part of her narrative. All right, back to you.
Great. Well, thank you so much, Dr. Day and Dr. Perrin, for talking a little bit about narrative medicine and how we were able to integrate that into our learning collaborative. I'm just going to run through a couple other insights from what we've learned so far, and then we'll wrap up with Dr. Conti and send you on your way. Just like we polled our participants in the Learning Collaborative around their knowledge and comfort with narrative medicine, we also asked them about their comfort and frequency of asking risk assessment questions for hereditary cancers. As you can see at the beginning of our collaborative, they were majority uncomfortable or neutral in terms of discussing hereditary cancer risk, but also in how often they discussed it. It wasn't nearly as much. We are currently collecting the data at the end of this to see if we've improved on these and they're more comfortable, and that perhaps they've been able to bring up those discussions more often. We actually know from some of our very initial first survey results of the collaborative that they have been bringing up discussions with patients using these materials. We also polled them to see if they were comfortable discussing genetic testing options and results with patients, and again, even more this time, uncomfortable or very uncomfortable or neutral on both fronts. We asked all of our collaborative partners to review many hours of these videos, to participate in the Cognito simulator, and generally they were very favorable in terms of their impressions of the materials. 100% of them reported that they felt that they would have positive impact, either by increasing provider knowledge or comfort with the topic, or by specifically increasing empathy. I think we heard a lot from our collaborative participants that it really gave them insight into the patient experience and made them more empathetic in terms of what might be happening in that particular patient or family. And they also benefited from seeing, they were more motivated, I think, by seeing the examples in the videos of how doctors and patients could work together. They learned new things, and they really felt that this could help them address their own personal biases or preconceived notions about patients and about the patient experience. So the vast majority recommended that they would, or suggested that they would recommend these videos to their patients. They would recommend them to other providers to use in training and to orient themselves to those discussions. So very successful review of the materials by our 10 participating residency programs. We also, though, wanted to get a little bit into why they might not use these materials. We all know how difficult it can be to change your care processes and integrate new learnings, new materials into the clinic flow. And we asked them in terms of specific categories, things like their own knowledge base and comfort level, things like, can it be integrated into your EMR to make it more efficient? Obviously, lack of time is a huge issue for all providers. And then things outside the practice that might be making it more difficult to use these materials, like a lack of community resources or knowledge of those resources. I won't go through in detail all the different things that the collaborative partners brought up as potential barriers or solutions, because we asked them for their solutions as well. But some just highlights from this: they really did feel that there needs to be more provider education in the residency training level on through CME, to talk about genetic testing options, helping patients understand their results, and things like insurance coverage. They knew that those questions were going to come up and they wanted to be better prepared to handle them. They talked about a lot of different strategies to make this more palatable and into the clinic setting, use of group visits, making sure that other staff, like physician's assistants, medical assistants, nursing staff, are all trained and familiar with these materials, because they may be the ones to be able to share them with the patient. Using in-office tools like tablets or iPads to actually have the videos linked and show them, so that the patient doesn't escape the visit and not really know where to go to find those videos. And linking these videos into your family history surveys and the online MyChart type functionality that you all have now in your clinics. We also noticed some language barriers. The materials right now are not in Spanish, but so for certain clinics that have a large Spanish-speaking population, that was a barrier. And then just needing to be able to follow up with the patients to make sure that they're actually using and viewing those videos, and you have some follow-up discussions with them. One thing we were happy about through this collaborative that we were able to do was add a QR code to the Bring Your Brave flyer, so that any patient with a cell phone, which is pretty much everyone now, could go directly to the videos and watch them. It made it just very easy, instead of having something set up in the practice for them to actually access those. And then with this, I'm going to turn it over to Dr. Conti to just give us our last few minutes of content, and it has to do with learning needs, what the residents came up with that they thought they might want to learn more about to make these materials more useful. Dr. Conti?
Yes, thank you so much, Scott. And I'm just going to take these last few minutes that we have with you to talk about can we integrate this resource into the residency programs. We all know that patient care is on one side of it, but also resident education, is on the other. And there's so many topics in family medicine specifically that we have to cover. And these are just a few that people have noted that really can impact their residency by using these resources. What I found most enjoyable about this list is that first one, finding greater joy and purpose in daily practice of family medicine. And if we can get every resident to do that, but equally, utilizing narrative medicine, enhancing empathy skills, talking about medical humanities, all can help build those topical references that we utilize in family medicine. Next slide. In addition to the topics, we talked about, how were residencies able to enhance or shape their curriculum by utilizing the Bring Your Brave resources. Some of that was, how they integrate in faculty meetings and doing presentations for faculty development, using those also for resident awareness and increasing resident knowledge. People have utilized them in externally recorded webinars for their medical communities or even for the populations that they serve, putting that information into newsletters. And then utilizing the Bring Your Brave as a QI project was also one of the things identified. Next slide. And lastly, being able to utilize, these are just a couple of examples of how the Bring Your Brave resources were used for resources. So one is developing perspective and empathy by utilizing those patient experiences before, during, and after hereditary cancer discussions or genetic testing, or talking about conversations with families, teaching those skills that allow residents to get actual training and how they're utilizing that. Building those skills and confidence in our residents by using some of the simulators that the Bring Your Brave campaign has. Residents were able to build up their skills to be able to better provide that patient care. And in particular, that knowledge development. One, understanding who is high risk and how do you identify them? How do you actually do a risk assessment? What are the things that we can talk about for risk reduction? And ultimately, learn more about genomics and genetics and what are the testing options, what are the pathways to referrals for our patients. And so with all of the patient care that we talked about, that resident and education piece is equally important, and wanted to make sure that you all had a chance to think about some of those opportunities. So I'm going to turn it back over to Scott to close us out.
Great. So thank you so much to all our speakers. We are right at the top of the hour, so I don't think we're going to have time for questions, but we are happy to answer them if you want to reach out to either me or Rebecca Boop, who is our consultant for this project. I just want to, as we wrap up, just want to say thank you again to all our speakers, in particular Dr. Welch, for joining us tonight, our advisory committee members who have been great in shepherding this project through the last 6 months, and especially to the CDC and the National Association of Chronic Disease Directors, who've allowed us to work on this project and hopefully are gaining some good insight from how we see family medicine using these materials and what it'll take to really make them part of routine care. If you're interested, we are going to be continuing this work into the future, doing more webinars, podcasts, other CME activity, but also doing a clinic-based quality improvement project. So we will be recruiting for that over the next month or two, and we hope you will consider joining. And with that, I'd like to wish everyone a great night, and thank you for joining.